So why don't we support testing for Lyme diagnosis? Well, it's not true. Our testing is same standard as the CDC. Okay. You can culture, as we mentioned, not very well. PCR and indirect serology is what we're using. I've already talked about the diagnostic test, so I won't stick with that. But the bottom line is, as I mentioned before, is like most testing that we do, serologic testing is fraught with cross-reactivity. So that's why the IgM test is not a very good test for diagnosis, because there's a lot of cross-reactions with other kind of illnesses, other spirochetes, etc. And the third bullet there about how long it takes, so it's not very good early on, as I've already mentioned, and the fact that it'll be persistent. So the serology doesn't go with the status of the disease. But I've said that 3 times now, so I've fulfilled my criteria for adult education. I've said it 3 times. I won't say it again. We're using two-step testing. This is very similar to what we do with Hep C and others. Basically, you have your screening test, which is the ELISA, and then you follow it by the Western blot. The reason why you just don't do a Western blot is, firstly, they're a lot more expensive, and you get a lot more cross-reactivity when you have all sorts of weird bands. So if the ELISA is negative, you usually would not go on to do a Western blot. And again, this is what we do for HIV, this is what we do for hepatitis C, etc. This is a standard, and our interpretation and algorithms are identical to the US. So the notion of the advocates that we don't have lab tests that are up to speed of the US is completely false. There may have been a time 10 years ago that the Public Health Lab in Ontario did not have standard up to snuff testing, maybe longer than that. That is no longer the case. And I can tell you, since SARS and the regeneration of that lab, when it comes to testing such as Ebola or Zika, the lab in Ontario, down in downtown Toronto, basically is developing labs virtually at the same rate that the national lab in Winnipeg is developing. And often we do a validation there because they have more techniques, but that is the quality of the lab testing that we have in Ontario and the quality of the people there in developing new assays. We're not taking a backseat to anybody now in terms of the ability to diagnose common diseases in Ontario. So this is what I want to mention about. I mentioned this before, but this is what I was so glad when someone actually did this, because this is what I want to do. So I'm seeing these patients who say they have Lyme. They come in with the IGNX thing, and sometimes they're being sent to me by these insurance companies because they want disability. And I'm going, no. And I kept always thinking to myself, boy, what I'd love to do is get a dozen patients who I know don't have Lyme disease because I'm seeing them for whatever else, diabetic foot, etc. And I'd love to send their lab results to this and see how many come back positive. The problem is it would cost me $150 a shot, so we're not going to do that. But here, someone actually did that and basically found out that about 60%, basically did not have Lyme's. So the bottom line is, they're saying that, so here's this lab that people are paying to get the testing done, and in fact, most of the time, the results are garbage. And this is what our patients are bringing to us when they go to see, these people in New York State. This is often the labs they're using when the conventional laboratories from the New York State lab are negative. So just keep that in mind. But think of how you're going to have that conversation with a patient who tells you, but doc, I paid this money, I have this result, you have to treat me.
Tonight on CBC, just as I was driving late,
No, please.
So there was a special on Lyme disease and how physicians are they have no knowledge base, and how the American testing is better, and that we need more advocacy. Virtually every health practitioner needs to be retrained because the Americans are right, and that's what the CBC. So everyone who is listening to this stuff comes in, and I have that same obtuse conversation about the fact that it's no better than what we're doing for testing.
And there's a private members bill that says the same thing.
From the Green Party.
Yes. Right.
Yep. Yeah.
Well, as you know, the private members bill is from an MPP, I believe, in Manitoulin Island. He's been on this for about 3 years now, and from the time he started, although I suppose he has people in the area, I don't know if he's affected or not, Manitoulin didn't have any infected ticks when this was all starting. So just to give you an idea, the nonsensical stuff that's going on. But of course, this is a person who's the MPP. He can have an audience. So apparently recently he had an audience with several advocates, patients who had symptoms, with the minister. So through all this, we're suggesting, well, if some of these people think they have chronic Lyme's, okay, we can do a study and treat them and show if it makes a difference or not. If someone wants to spend the money on it.
For-profit labs in the United States, it's not unique to Lyme's disease. We see the same thing with celiac testing, where the tests are rubbishy. Positive tests are just rubbish.
Yep.
So it's a medical industrial complex as well as the military industrial complex we have to worry about coming out of the United States.
Mm-hmm. Well, I mean, it's the issue of for-profit system. It's like if someone pays for something, they want to get something for it, and I guess if you tell them what you want, they'll give it to you, I suppose. So, I mean, this is just NIH saying, yes, it would be nice to do more research in the area. Exactly what that means, or we're going to get better PCR testing or things like that, I don't know. But, I mean, it would be nice to be able to confirm Lyme very early on, from what I meant. It would be nice to know later on to be able to differentiate persistence of disease versus just immunologic response. But Lyme's isn't different than most other diseases that way. I mean, that is the limits of our diagnostic capabilities. And let's face it, this is what we've been learning over time, that we used to treat community-acquired pneumonia for 10 days, and even at 10 days, the x-ray was still showing signs, and now we know don't bother doing the x-ray because the x-ray is still going to show evidence of inflammation, and 5 days of therapy is more than enough. So we're showing that prolonging therapies based on some of these signs is actually not the key, because a lot of what you're seeing is inflammatory and non-infectious. But it would be nice if we had silver bullets that actually told us exactly what's going on. But I think it's a bit, not even sure, pie in the sky to think that we're going to have tests that are going to be that specific and that accurate and that timely. And maybe one day we're going to have it because it'll be just like, Star Trek, and we can just go like this and get our instant answers. But I don't think any of us here are going to be in practice when that technology exists.